You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. This episode's guest is Dave Navarro, Senior Director of Data Science for Harmony Health IT, a data management and lifecycle solutions firm. Dave joins the Dish on Health IT host Ken Kleinberg and co-host Jocelyn Keegan to talk about 21st century cures and the change in definition of EHI, critical components of data lifecycle plans to purge, archive, or transition data to new platforms, and how to marry data in various formats and versions of CCDA and FHIR and other standards. We hope you find today's episode informative and helpful. If you have topic ideas you'd like us to cover in future episodes, be sure to share them with us by emailing us at podcast@pocp.com or tweeting us at POCPHIT.
Hello, everyone, and welcome to The Dish on Health IT, where we invite health IT leaders and trailblazers to break down and discuss some of health IT's biggest news and most exciting milestones. We at Point of Care Partners are health IT consultants. We work with stakeholders across the healthcare ecosystem and are viewed as an independent and trusted party. I'm Ken Kleinberg, Innovation Lead here at POCP, and I'll be your host on this episode. I'm joined by my colleague, Jocelyn Keegan, Payer Practice Lead here at POCP, and the Program Manager of the HL7 Da Vinci Project. We're excited to welcome our guest, Dave Navarro, Senior Director of Data Science, Harmony Health IT, a data management and lifecycle solutions firm. We'll be talking with Dave today about 21st century cures and the change in definition of EHI, critical components of plans to purge, archive, or transition data to new platforms, and how to marry data in various formats and versions of CCDA and FHIR. Before we get to our guest, I'd like to have Jocelyn briefly introduce herself and tell us what she's looking forward to learning from today's podcast guest. Joss?
Awesome. Glad to be here and actually super excited to talk to Dave. We were in our prep sessions discussing how our worlds between the three of us have not collided until now. I'm excited to hear from the Harmony team and the work that they're doing. I am, as Ken mentioned, our payer practice lead. I spend my days basically sort of at the intersection of interoperability, prior authorizations, where tech standards and product strategy come together in my day-to-day consulting work, as well as in the leadership role on Da Vinci. I really love the idea of figuring out sort of what is working well and how do we do more of it and where do we need to continue and grow. I'm a product manager by training, and I think that this idea of incremental improvement is really important. So excited to talk to Dave today and hear about sort of the work they've been doing around, really capturing sort of the historical record of patients and making that data more usable if we think about sort of the evolution that we're going on and interoperability becoming real in the industry today.
All right, thanks, Joss. Now, let's greet our guest, Dave Navarro, Senior Director of Data Science, Harmony Health IT. Dave, would you briefly introduce yourself, give us a little bit of your professional background and your journey to Harmony Health IT?
Sure. Thanks for the introduction, Ken, and nice to meet you, Jocelyn. As mentioned before, I am the Senior Director of Data Science here at Harmony Health IT. I started my career about 22 years ago in the health IT world, so it's been a while. Started off by configuring EHRs, building clinical integrations for financial systems and clinical systems for Cerner Corporation. Early on, just a lot of exposure to different data formats, fixed link files, etc., HL7, CDA, all of that kind of good stuff. So took that experience, and I've been spending the last 17 plus years in the health information exchange world. Probably call me crazy, but I guess I am if I spent that long in the health information exchange world. So implementing all those good things, IHE profiles, again, HL7, all of that kind of good stuff, things that come along with health information exchange, such as master patient index and all of that good stuff. And then I landed here at Harmony to really work on the interoperability piece for legacy data and the legacy data solutions that we're providing here.
All right, thanks, Dave. Well, before we jump into the deep end of our topics, could you tell us a little bit more about the work that Harmony Health is doing?
Oh, sure. So we're all about taking care of the client's legacy data needs. So what is legacy data? You may ask yourself that. Well, it's really all the information that's stored in a soon to become obsolete system is really what we see here, either because the client's moving away from that system or the system's being sunsetted or a variety of different reasons. We need to get that data. They need to get that data extracted and stored in a place that makes sense, that they can manage that data, they can view that data, and then make clinical decisions on it. So our solution for that is what we call the Health Data Archiver solution, where clients can go in and take a look at that data. We provide the extraction services. So if you've got a legacy data system, if you hand over your relational database, or if you hand us flat files, we can extract that data and put it into our repository. We also take that data and do some migration services. So there may be some of that data that you actually want moved over to your go forward system. We've got a process where we change that into an HL7 CCD message, and we ship it along to the client so they can post it in their system. We also have some AR wind down services. We've got a product called AR Manager. So when you're looking to sunset that system, can we take those claims and payments and keep track of those for you? So.
All right, thanks. All right, so let's start out by talking about 21st century cures. In the history of health IT with HIPAA, with ICD-10, with meaningful use, this is a big one, and it's having some far-reaching impacts across the industry related to interoperability and specifically this topic of information blocking. So could you tell us a little bit about how you view these new 21st century cure regulations, the positives and the negatives?
Sure. So the 21st Century Cures Act, I'll be honest, I haven't read the entire thing because it deals with a lot of stuff. But what I have been focused on is the interoperability provisions. So that's what we're probably talking about here today. And we're really keyed in on what that's doing for us. I think the 21st Century Cures Act is a really good thing. I mean, it was signed back in 2016, I believe. So, I mean, we're just now seeing the fruits of that labor come to fruition. So I think it's a good thing in the way that it's actually started pushing the industry. Hey, let's go ahead and adopt content standards such as USCDI, and let's adopt transmission standards, still talking about the HL7 CDA, but we're also moving on to FHIR. So it's really pushed the industry to adopt certified health information technology, which would be able to exchange data via FHIR and really standardize that data exchange process. So overall, I think it's a good thing. I think most people are excited about it. There's a lot in it. So maybe they don't understand everything and we have to go back and read it several times, but it may take several times to read through, but the provisions for interoperability, I think, are really good. There's also the data blocking provision, which we all heard of. Nobody wants to be a data blocker. So how do we open up that data stream and make data available where EHRs and ultimately patients can view the data and not be blocked from seeing their own clinical data?
Yeah, well, we talk about the industry as a whole and 21st century cures as positive, although there are so many stakeholders in healthcare, they may not all see it that way. What are your views on how this affects various stakeholders? And is there a particular perspective you wish that everybody could get around so that we didn't see this as a zero-sum game, that there was actually a lot more to gain?
I think the industry, if we can get around, where I started with the 21st Century Cures Act, I automatically saw FHIR. So FHIR is a little bit scary. We've all been trying to get through HL7 CDA, and we're still working on HL7 version 2. What I would say is let's start with FHIR. Start with that specification, because I know that we've looked at other specifications in the past, like HL7 CDA, kind of hard to figure out what it's talking about. The FHIR specification and the implementation guide for the US core data set is a really good specification. It's put together well. It's on the, it's published well. There's links. You can actually look at that specification after looking at it for about an hour, you can pretty much figure out terminologies that's being used, implementation methodologies, just the structure of the data. So if you take a look at that specification and then you compare it to how you're storing data or how data is stored in your system, it's not an architecture guide, but it can really be used to help the architecture of the system, to help you make decisions when you start when you start archiving data or when you start storing data in any method. I would really take a look at that because it really builds on all the work we've done from HL7 version 2, HL7 CDA, HL7 version 3, all of that. It really builds on all those lessons learned, and some of the things that we may not have liked about those previous specifications, a lot of those things are fixed. So just looking at that specification gets you in the mindset of what type of data you should be, number one, exchanging, but how that data should be stored.
Let's bring Jocelyn into the conversation, especially around how 21st century cures might be different for payers and providers. Joss, you've been involved with Da Vinci for so long now as program manager. What are you seeing in your day-to-day with Da Vinci and how payers and providers are reacting to these regs?
Yeah, it's really interesting. I think that everything that Dave's saying is so incredibly important. And I think that when we look at sort of what's happening around 21st century cures, we've got this upcoming deadline that's happening with EHI for the beginning of October. And I do think that as much as folks are sort of gearing up, making their plans, getting ready to transform, we're seeing a little bit of indecision in the industry of what does it mean to meet that October deadline versus what I think we're all focused on, which is end of year, all of the certified HIT vendors really moving up to that US CDI 3 and FHIR R4 capabilities. I think that's sort of the next logical step. And there's some confusion from an implementation community perspective about how that's going to be impacted by sort of the everything needing to be available in October. And I think that this is a really good place to ponder sort of like where is the place we come together as an industry and talk about clinical data exchange sort of holistically and not from their stakeholder seat, because I think that people are looking for additional guidance as they're going to make investments on the vendors that they're picking or the way they're platforming and storing their data to really understand sort of what do they need to do to unleash data out into the industry. The people that have been at it for a while, sort of the folks that I get to work with on a day-to-day basis understand sort of this idea of going sort of dollar signs, everything, FHIR isn't necessarily going to get us to the semantic interoperability that we want to get to, but that really this idea of getting to, using the guides, using the more advanced workflow-based guides, helping us get to this point where we can get to the semantic interoperability requires. So I think everyone appreciates we need to keep moving forward. I just feel like there's even more as people understand the October deadline, some confusion in the industry about what does it really mean to be compliant and enforcement around, what data is going to be bare minimum for these actors to be able to share to the industry. And I'm curious, because I know Dave's been probably having these conversations day to day over the last year or so with his customer base, how that's going. Like what are people actually, how are they grappling with it?
Yeah, so let me ask you about that, Dave. With your storage of information and what organizations might want to archive versus what they need to share. So as Jocelyn brought up, we're moving from US CDI to all of EHI this fall. What do you think this means to the industry and to Harmony?
It's a big move. I'm used to working in a finite list, and I think our clients are like, I need a checkbox to check off that I've got 32 elements or 64 elements or whatever, however many elements are in what version of the US CDI. So the first question we get from our clients is, hey, October 6th is coming up. I've got this deadline. I need to provide data to my patients. And I said, okay, so what were you doing? Let's take a look and see what you were doing in April of last year, because there was a deadline back there too to provide content based on, I believe it's US CDI version 1. So what was that process like? Because I want to know if they went through a specific process. And guess what? I haven't heard not one of my clients that went through a specific process of going through version 1. I don't know if we were all asleep at the wheel or what, but October 6th, US CDI, or the content of EHI, the definition of EHI is changed to everything. So my recommendation is, number one, we have to start somewhere. We have to start with a finite list. The finite list that I can apply to all my clients is, let's start with US CDI version 3. It is the latest list. Let's make sure you're contributing that. The next question is, well, what's next? What is everything? I can't answer that question, but what I can do is I can give them guidance to go back to their legal team and their medical record team and say, what is your HIPAA designated record set? That should be a place to start as well. Now, we haven't figured it out, and they haven't figured it out yet, but I think that there's a fine line of, hey, let's get what we have, the minimum check boxes that we can check, which is US CDI version 3. And also let's start taking a look at our HIPAA designated record set and let's see where we can meet in between those. On the industry side, I have to start somewhere, and I'm starting with US CDI version 3. That is where my starting point for providing content would be.
And so I think that the challenge here, and I love the way that Dave approaches this, because we saw this on the payer side with the patient access API deadlines that got pushed to last July, is this idea that first people need to figure out all the places they were actually storing clinical data. And I think that often in large organizations that often have grown by acquisition or, in sort of siloed sort of subject matter areas or lines of business inside the organization, that things aren't consolidated in a way that we would think would be, that would be easy to get data to be able to transform it, to make it readily available, sort of with the timelines that are required for some of these requests. And so that exercise, each group sort of going through that exercise is important. And Dave, I like the way that you're approaching it. Like, let's figure out what the minimum floor is. I think that it does beg the question to say, is there a conversation we need to be having as an industry? And I'll use the parallel to Patient Access API again. We had a group of payers, part of Patient Access API required the sharing of all data, clinical data from one payer to the next payer when a patient changed coverage. And we were in the midst of building an implementation guide inside of the Da Vinci community, focused on literally doing this in a codified way that would be more in line with US CDI as the core content set, but also all of sort of the provenance and sort of customization of profiling of FHIR resources, to get a little technical for a second, of what it really means for a payer to share clinical data to another payer or even to a provider. And a group of the community, and I would say it wasn't just the payers, we had a couple of providers that said, let's do this right, actually issued a statement out to the industry that said, hey, we want to share this data. We want to make sure that we're doing it in a codified way, that it's, and there's some really strong visuals that they created at this point in time. We want to make sure that the data is going to be usable and shareable going forward. If we sort of enter this blob of unstructured data into the industry that isn't formatted in a way that it's usable, that blob is now going to go across and follow that patient for their whole sort of time. And so essentially the industry, I think, gave CMS feedback, and CMS has basically had held sort of the requirement for payer-to-payer implementation until I think we expect that they will recommend using a standard IG-based solution that will get us more akin to sort of US CDI 3 plus, the specification of how to do this for this particular use case. And I think one of the challenges we see in the industry right now is that there isn't a similar sort of cross-functional group thinking about how this is going to happen, both on the EHI side of the world, but also just in general as we think about sort of other industry activities like the alignment of CCDA transitioning over to FHIR, as we think about things like TEFCA rolling out. So I think the question that we need to ask ourselves, and I'd be curious to know what you guys think, is, how much are we asking ourselves, how much of the data needs to be cleansed and codified, and how much data is it okay remains unstructured, historical, when somebody needs to dig into it and becomes available, and it's okay to apply ETL and AI to it. And I don't know that we've really grappled with that in a meaningful way as an industry versus sort of people checking the box, right, of what they need to do from a certification perspective.
Yeah, Dave, please take that one on.
Sure. I agree with you, this checking the box. I live in the historical archive world. So when we're archiving systems, somebody just wants to check the box. I just need to get this done and I need to push it over. So for years, we've been checking the box, or they've been checking the box. So going back to what the good thing is about the 21st Century Cures Act is, wait a minute, I just don't need to check the box. I need to make sure I have structured data. I need to make sure that it is codified in some way. If it's not codified, I probably should worry a little bit about it, because that data never goes away. So I've done eventually it may go away, but I've done a couple of migrations where we're, I'm on the EHR side outside of Harmony, and I'm on the EHR side, and we want the minimum pieces of data. And so when you're looking at the minimum pieces of data, that's fine, but they may only get 2 years of lab results or 2 years worth of vital signs or things like that. And just the 21st Century Cures Act pushing for patient access of all their data has really changed the mindset of our clients. So now, instead of I only want 1, 2, 3, and 4 pieces, types of data, it's really here's what I think I need. Can you give me a little bit more consulting on making this interoperable later? And may not be interoperable day one, but eventually those provisions are going to come into effect, and I need to be able to query a repository, pull medications back to reconcile them, pull problems and allergies back in a format that can be reconciled into an aggregate form that can be provided back to the patient. So those questions are new questions that we haven't gotten until probably this year.
Yeah, well, that's leading into the challenges of what you do and how hard it is. I would think you have clients coming to you that are relatively naive about this, or others who have been down this road and made mistakes in the past. Where do you see the larger challenges, and why do they need a firm like yours to help them?
So where do I see the challenges where our clients are and when they're coming to me with this information? So the good news is some of our clients, we actually, they're able to hand over an entire copy of the database. So we've got a team of analysts that knows what to look for now, that knows to make sure that we're not just picking medication signature lines, that we're actually looking for an NDC code or an RX norm code or something like that. So with the clients that hand us the data, it's a little bit easier because we've got the expertise in-house to go pick it out and pull it out. Sometimes we don't have the choice, or they don't have the choice, and they get a record format, a delimited record format that is sent out, and guess what? You're looking at a medication signature line that just has the text and no codification. Same thing with problems and allergies, things like that. So you get really good information. However, it's not codified. So the challenge is, what do we do with that? What can they do with that? Can they modify their extracts? Sometimes yes, sometimes no. And that kind of leads us into this AI piece. Are there industry, the industry built around, hey, I've got a medication signature and now I need to codify it somehow. Is there enough information in there that I can provide an RX norm code or an NDC code to that? So,
do you give your clients any type of an audit tool or some way to codify or categorize what they have? How do you help them along with what must be a very difficult process at their end?
How we help them along is kind of what I mentioned earlier. I've got a guideline specifically directed, the directive by the 21st Century Cures Act. So let's take a look at the data elements that are in the US CDI. Now, apart from that, you can take that US CDI specification. It's great. That US CDI specification, it's great, but it's just words, right? It's just text. So how do I change that text? How do I apply that textual definition of a data element to something really meaningful? So we've taken that US CDI spec, and then we've cross-referenced it as FHIR has and the US Core Implementation Guide. So really that specification of US CDI married with the US Core FHIR implementation for US Core, US CDI, we've taken that, and that's our directive. We say, hey, let's take a look at the codification for those types of elements, let's make sure we try and get those from you or understand where in the database they are. Because if that does not happen, there's going to be future use cases where you move to your next EHR, and that next EHR is going to have FHIR capabilities and be able to query and retrieve data. And when you query and retrieve that data, the functionality that they build in, such as reconciliation of medications, or building an aggregate document, may not work because you don't have that data. So we really go through, start with USCDI, but break it down and say, let's take a look at a CPT code for procedures. Let's make sure we have those CPT codes for procedures. Also, same thing, not just codified elements. When you look at medications, for example, I need to know if that medication was just documented or that medication was actually prescribed by you. That FHIR specification is awesome for figuring out those questions. So as painful as it must be, I have been through every single element in the FHIR specification for US Core. And it sounds painful, but it's really not, because the specification's put together really well. And that's where we derive our questions. That's where we derive our guidance.
All right, thanks. From my perspective, this USCDI is one of the greatest advances we've had to get us all on the same page moving forward. I'm really a fan. But let's shift gears for a moment to consent. Joss, you've worked a lot with e-consent. How do you see this playing out? What can we do technically? And I'm hoping that Dave will want to give us his perspective on what Harmy has done here.
Yeah, I think it's interesting. We had the workshop last month with ONC, really bringing together for the first time, I think, again, creating a place, convening people to talk about this in a common group with stakeholders being represented really in all of the different use cases across the care continuum and timeline of where we need to make sure we're really being thoughtful and strategic about surfacing the abilities, control, and monitor and share consent, right, from a patient perspective, beyond sort of what we do today, which is sort of we check it at the front door, and then we're sort of on the honor system, right, as data flows throughout the industry. And as we get more to codified data and sort of less big blobs, unstructured data, the ability to control even a lower level, some of the information becomes more critically important, especially as we look at some of the privacy components, right, around closely held information the patients wouldn't want shared, beyond sort of the provider that's practicing in that area. So I think that, it'll be interesting to see sort of how that works. But I think we're in the culmination of now that the data is being freed, allowing people to start to share best practices and some of the emerging technology that is actually happening out there for real. But I am curious, when we think about this archival information, how does that work, and where is that sort of lever or that permissioning happening as we think about sort of that patient data, that's being archived off?
I'm most familiar with consent in my HIE world. So as being part of the HIE here in Indiana for the last 17, 18 years, consent was at the top of it. E-consent was at the top of it. On the Harmony side, where I've got a data archive here, the expectation would be, number one, I would certainly love to store consent information, historical consent information. So that should probably be on the top of my list. Does it exist? I'm not exactly sure in all the systems that I'll be archiving, because they probably weren't interoperable. They probably weren't on the eHealth exchange. Maybe they were or were not. So the way I see the e-consent working with the archive is, the archive really is an ancillary system. So if we open up the archive to things like federated queries, so if the organization, their go forward EHR is on the eHealth exchange, they're receiving queries for data. And what I'm thinking is that consent, the most recent consent, should exist in the EHR. And then there would be the EHR's decision to federate that query, to either process that query and then federate that query down to the archive. And that federation only works, again, as long as we have all of that data, the discrete data, as much as we can stored in the archive. So.
Yeah, and I think I see this, Ken, as we go into sort of these detailed conversations about specific scenarios and how the data is going to be retrieved, is I think what we live in is a world of best practices today. And what we really need to do as we look at scaling and really this becoming a reality sort of across platforms, and patients being more and more empowered to retrieve the information with their app of their choice is a need for us to, I think, have more solidified, rules of the road as this happens. More holistically, as opposed to sort of individual ecosystems. But I think that one of the things we heard in the day-long session that we did with ONC was, as much as we want holistic solutions, really what is happening today is something that works for the specific situation with the specific stakeholders, and those decisions really being made locally today to the best practices of a particular community. So I think we've got our work cut out for us figuring out how we're going to do this more broadly across the industry.
And Jocelyn, one more thing that you had mentioned is the segmentation of data for privacy. I mean, that is something that the industry has been really wanting to do for the longest time. That I don't know, data, the DS4P specification. So when we're living in the HL7 world, and you're transmitting a CDA, or when we're living in the CDA world and you're transmitting a CDA document, there's certain things that you can do in that document or to share or not share. So you're looking at really making sure that data is stored properly so you can apply segmentation at a more granular level. Yes, I want to share allergies. Yes, I want to share medications. No, I don't want to share problems. Really putting that decision in the patient's hands. And I think it's a great specification and great thought behind it. I think hopefully eventually that'll come to fruition.
How we actually make it work right for real in industry. Yeah. Ken, if you don't mind, I would love to segue to the other conversation that we had during prep, which was this idea of what does that convergence of, I think that people have really thought about, FHIR is going to replace everything to date. And, as part of our sort of prep, and I think more and more in the industry, we're having this conversation about right? How is CCDA going to continue to exist? We very rarely turn capabilities off and walk away from investments, and there's been significant investment there. How does that, I'd love to hear Dave's thoughts on sort of how that coexists and evolves with this incremental move of us to APIs and FHIR.
So as much as I've been talking about FHIR, I don't have anybody yet with FHIR capabilities coming to query and retrieve data for me, from me. What I do have, which is a little bit outside of the archive. What I do have is that clients that are on the eHealth Exchange or part of Commonwealth, and they're familiar with exchanging data and via those networks. And what they're doing is they're exchanging data in HL7 CDA format. So they put a lot of work into that, not only to generate those, but also to receive those, consume those, reconcile pieces of data in them. So from the archive side, I would love to go to a pure FHIR world. That's not going to happen because that's not going to happen January 1st of 2023. What can happen January 1st, 2023 is guess what? You make a request for a document, a CDA document. You request that CDA document over FHIR. I can return that to you because that's something that you're used to consuming. You know what to do with that. Maybe you have to build in the FHIR capability to query and retrieve it, but once you've got the format back, that's kind of a known thing that you've been doing for a couple of years now, is consuming a CDA document. So that's really on the first of my list when I'm building FHIR capabilities is let's see what folks are doing now. We certainly want to do all the FHIR transactions that are in the US Core implementation guide for FHIR. We want to do all of those. But I know today that they can handle a CDA document because I'm sending CDA documents and other methods right now. So let's make sure that that's available day one.
I've still got some CDs in my closet. And I probably still have a couple of the 3-inch guys, but we don't have to go there. Dave, as we get to the end of this podcast, an opportunity for you to get up on a soapbox, give your industry ask, what would you like to see from the industry?
Well, I know it sounds like a cliche, but interoperability is a journey and not a destination. If you heard me say this before, we're not going to be all fixed January 1st, 2023, or all fixed on October 6th of 2022 this year. What I mean by that is we're not going to solve, interoperability is not solved with just FHIR, as you had mentioned before, Jocelyn. It's going to take a lot of work and a lot of FHIR integrations running smoothly before we get to this place. And the one thing I would like to say is if you're storing data, if you're receiving data, there are some great models and some great implementations that came way before FHIR. I would certainly use FHIR, but if I'm storing data, let's take a look and see how it was done in HL7 version 2. Let's take a look how it was done in the HL7 CDA specification, and now let's take a look at FHIR. Put all of those together. Now, FHIR has done a lot of that work for you, but there's a couple of things that may not totally fit there. But take a look at how all of those specifications have transmitted data, have documented their specifications and what terminology is used, etc. And when you're storing data, let's make sure that any format that you create, you can create out of a well-formed database and or data model that's built on these specifications. So that's what I would say is use these specifications as a guide. They're not all of them are data models. FHIR is not a data model, but it's a really good specification that you can use when you're storing data. And once you store that data correctly, you could produce CDA formats out of it pretty easily, or FHIR transactions, or HL7 version 2 transactions out of that can be too.
Okay, great. I want to thank my Point of Care Partners co-host and interop expert, Jocelyn Keegan, and thank our knowledgeable guest, Dave Navarro from Harmony Health IT. Friendly reminder to new listeners to our podcast that you can find us on Apple Podcasts, Spotify, or whatever platform you use to pick up your podcasts, including Healthcare Now Radio and the podcast channel. We'll hope you leave us a positive review if you find our podcast informative. Videos of our podcast episodes, sometimes longer versions, are also on the Point of Care Partners YouTube channel. And don't forget, especially as we transition from summer to colder temperatures, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interopoutlook@pocp.com to learn more about our new Interoperability Outlook subscription monitoring service.